Hello and welcome. Today we're diving deep into a relatively rare but significant kidney disease, light chain deposition disease, or LCDD. We'll explore what causes it, how it affects the body, how it's diagnosed, and what treatment options are available. So let's get started. The underlying cause of LCDD is the overproduction of abnormal light chains, which are components of antibodies. These light chains are produced by abnormal plasma cells in the bone marrow. Now, this isn't quite multiple myeloma, although there's often an associated clonal plasma cell disorder. These light chains, specifically the kappa type more often than lambda, are misfolded and prone to aggregation. The exact trigger for this abnormal protein production is often unknown, making LCDD a complex disease to pinpoint its origins. Here's where things get tricky. These abnormal light chains circulate in the bloodstream and deposit in various tissues, most notably the kidneys. In the kidneys, they deposit within the glomerular basement membrane, tubular basement membrane, and the mesangium. These deposits cause thickening and damage to these structures. This interferes with the kidney's ability to filter blood and reabsorb essential substances, ultimately leading to kidney dysfunction. The heart, liver, and other organs can also be affected by light chain deposition, leading to widespread organ damage. LCDD is considered a rare disease, making it difficult to accurately determine its prevalence. It typically affects adults, often between the ages of 50 and 70. However, it can occur in younger individuals as well. While research continues, there's currently no known predisposition based on race, ethnicity, or geographic location. The rarity of the disease also makes gathering comprehensive epidemiological data challenging. The signs and symptoms of LCDD can vary depending on which organs are affected. The most common presentation involves kidney dysfunction, leading to proteinuria, which is protein in the urine. Over time, this can progress to chronic kidney disease and eventually kidney failure. Patients may also experience edema or swelling, particularly in the legs and ankles. If the heart is involved, patients might experience shortness of breath, chest pain, and arrhythmias. Other possible symptoms include fatigue, weight loss, and symptoms related to liver or nerve involvement. Diagnosing LCDD requires a multifaceted approach. Initially, blood and urine tests will be performed to assess kidney function and detect proteinuria. A kidney biopsy is crucial for definitive diagnosis. The biopsy sample is examined under a microscope, and special staining techniques, such as immunofluorescence, are used to identify the presence and location of light chain deposits. Bone marrow aspiration is also typically performed to evaluate for an underlying plasma cell disorder. Serum-free light chain assays can also be helpful in identifying abnormal light chain production. While LCDD doesn't have subtypes in the traditional sense, it's crucial to classify it based on the type of light chain involved, kappa or lambda, and the presence or absence of an associated plasma cell disorder. The severity of organ involvement, particularly kidney damage, is also an important factor in determining the stage and prognosis of the disease. Identifying any underlying hematologic disorders is paramount for tailoring treatment strategies. Treatment for LCDD focuses on reducing the production of abnormal light chains and managing the symptoms of organ damage. Chemotherapy regimens similar to those used in multiple myeloma are often employed to suppress the abnormal plasma cells in the bone marrow. Medications like bortezomib, cyclophosphamide, and melphalan may be used. In some cases, autologous stem cell transplantation may be considered. Supportive care, including medications to control blood pressure, manage edema, and treat anemia, is also essential. If kidney failure develops, dialysis or kidney transplantation may be necessary. Currently, there are no known preventative measures for LCDD. Because the underlying cause is often unknown, primary prevention isn't possible. However, early diagnosis and treatment can help slow the progression of the disease and minimize organ damage. Individuals with a known plasma cell disorder should be closely monitored for signs of LCDD. The prognosis for patients with LCDD varies depending on the extent of organ involvement and the response to treatment. Early diagnosis and aggressive treatment can improve outcomes. However, many patients eventually progress to kidney failure. Recent research is focused on developing more targeted therapies that specifically target the abnormal light chains. Clinical trials are ongoing to evaluate the effectiveness of novel agents, such as proteasome inhibitors and monoclonal antibodies. Further research is also needed to better understand the underlying mechanisms of LCDD and identify potential therapeutic targets. The hope is that these advances will lead to improved outcomes and a better quality of life for patients with this challenging disease.